Welcome back. It's Dr. Lindner. Let's take a look at things that can influence blood pressure. So here we have some normal blood pressure. Remember, normal blood pressure is supposed to be less than 120 over 80 millimeters of mercury, less than 120 over 80. This is systolic and this is diastolic. So there's something that's happening that's increasing the pressure. And we have pressure receptors called baroreceptors. These are pressure receptors that we have in the carotid arteries, the carotid sinuses, and along the aortic arch. When it detects that the pressure is hitting those walls with intensity, it's going to send the signal to the neural system. And the neural system is going to say, hey, we got a problem. We need to decrease the sympathetic output. When you decrease the sympathetics, remember, sympathetic is fight or flight response. So when you decrease sympathetics, you're going to decrease your heart rate. When you increase sympathetics, you increase your heart rate. If you decrease sympathetics, you decrease heart rate and you decrease the contraction of the heart. And at the same point in time, you're going to dilate these blood vessels. They open up, which decreases the resistance in the blood vessel. So if you decrease the resistance and you decrease the cardiac output, your blood pressure normalizes. Okay, now the opposite is true too. You can have something that creates a decrease in blood pressure. The same baroreceptors in the carotids and the aortic arch detect that, send signal to the neural system saying, hey, let's increase the fight or flight response. Let's increase sympathetics. So we increase the heart rate, increase contractility, and the lumen size, you get that vasoconstriction. The vessel constricts, the lumen gets narrower, which increases the resistance of blood flow inside here. So when you increase the resistance and you increase the cardiac output, you increase the pressure, normalizing the blood pressure. Let's not forget the RAS system. You probably learned this a little bit when you did the endocrine system. The renin, angiotensin, aldosterone system. Now renin, if we look at the first three letters of renin, it looks like renal. So renin has something to do with the kidneys. Angiotensin, angio means blood vessel, tensin sounds like tension. So this is going to have to do something with the tension of the blood vessels. So we have the liver, and the liver makes angiotensinogen. Now, if you've had me for AMP1 or if you've listened to any of my other videos on my YouTube channel, you'll know that anything that ends in -ogen is inactive. Whether it's pepsinogen, glycogen, angiotensinogen, they're all inactive. So angiotensinogen is what the liver makes. Your kidneys make renin. And when renin bumps into angiotensinogen, it knocks off the ogen and we get angiotensin 1. Now, if there's an angiotensin 1, it's safe to assume there's going to be an angiotensin 2. How do we convert angiotensin 1 into angiotensin 2? Well, that's easy. What converts angiotensin 1 into angiotensin 2 is something called angiotensin converting enzyme, or we call it ACE for short. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. What does angiotensin 2 do? It vasoconstricts your blood vessels. When you vasoconstrict, that's going to increase your blood pressure. Angiotensin 2 also stimulates aldosterone. Aldosterone is a mineral corticoid that says, hey, let's hold on to sodium. And if we hold on to sodium, which is a mineral, we're going to retain water at the same time. When you increase salt and when you increase the retention of sodium or salt and we retain water, we increase blood volume, which increases blood pressure. Okay? Now, what angiotensin 2 also does is that it's going to increase your salt cravings. So all of a sudden you're going to crave something salty. And then what happens after you eat salty pretzels or salty potato chips? All of a sudden it increases your thirst. Angiotensin also stimulates antidiuretic hormone. So think about this. You get salt cravings. Now the salt that you eat, we got aldosterone that's going to hold on to sodium. Then you get thirsty. You got increased thirst. Well, aldosterone doesn't only hold on to the sodium, it holds on to the water that you drank. So you increase salt, you increase your thirst, aldosterone holds on to the salt and water. And not just that, now you have antidiuretic hormone. Diuretic makes you urinate. Antidiuretic holds on to the urine. Pretty wild, right? Okay, so let's take a look at the next slide. So besides this, we also have some hormones that are involved. So ANP, atrial natriuretic peptide. What's the first two letters of natriuretic? Na, just like NaCl, sodium chloride. So atrial natriuretic, Na is for natrium, which is sodium. Atrial natriuretic peptide is saying, hey, we got to get this is the heart. The heart is producing a hormone to regulate its own blood pressure. It's saying, hey, let's get rid of the sodium. Let's get the sodium out. If we can get the sodium out, we could decrease the blood volume and decrease the blood pressure. Then we have some amino acids. One of them is called arginine. You have arginine. When arginine comes together, arginine is a precursor to nitric oxide. Nitric oxide is a vasodilator. It opens up your blood vessels. It too decreases blood pressure. Histamine is a vasodilator. That's why when you get a sprained ankle, the body releases histamine and your ankle turns red. It's hot, inflamed, and swollen. It's a vasodilator. Prostacyclin, that's a blood thinner. So they're all thinning the blood and dilating the blood. All of that decreases blood pressure. Alcohol causes your blood pressure to drop because it inhibits antidiuretic hormone. Now, when we look at blood pressure, we want the normal blood pressure to be less than 120/80. Less than 120/80. If it's less than 120/80, it's normal. Prehypertension is when it's just above 120, but less than 140. So if it's 120 to 139, right? If it's 120 to 139 over 80 to 89, that's prehypertension. High blood pressure is when it's over 140/90. The top number is systolic pressure. The bottom number is diastolic pressure. Systolic is the pressure when the heart is contracting on the blood vessels. Diastolic is the pressure on the blood vessels when the heart is relaxing. So that's why diastolic was seen with repolarization and systolic was seen with depolarization. Okay. Now, when blood pressure is taken, it's very important that the arm is held out perpendicular to the trunk, right, at a 90-degree angle, and that the arm is being stabilized. You can see that my hand and my fingers here are underneath this patient as I'm taking the blood pressure. Her feet are flat on the floor. And blood pressure should not be taken on just one arm. You should always take blood pressure bilaterally. There are many instances in which I've taken blood pressure where it's normal on one side and very high on the other. And that's because you can have inflammation on one set of blood vessels on one side of the body and not the other. There are times where it was normal, and then I had to send the patient directly to the hospital because these numbers were like stroke material on the other side. And should always check the numbers at least twice on each side, not just once. I check it twice to make sure that it's backed up. Because let's say, God forbid, something happens and they say, Dr. Lindner, what was her blood pressure? And I say it was 120/80. And they said, which arm did you check? I checked her right arm. How do you know it was 120/80? Well, because I checked it. How many times did you check it? Once. Well, is there room for error if you just do it once? Of course there is. But if you check it 2 times, it's either you're going to get another number or it confirms your first reading. So it limits the amount of malpractice as well. You want to be thorough. You really want to be thorough. Pretend that everyone on that table is your child, it's your parent, or it's a grandparent or relative. And in terms of pulses, you can feel pulses throughout the body. This one here is very important, because especially in smokers. If you have a smoker and they're having headaches and they're feeling like the side of their head here, you want to palpate that and listen to make sure that you don't hear any type of bruise, abnormal blood flow, or stagnation in that area, because this can lead to blindness. It's called temporal arteritis, big time in smokers. Here's the SCM muscle, the sternocleidomastoid, and just superficial to it is the common carotid artery. So when people are running and they're checking their pulse, they often put their fingers up at their neck. They're checking the common carotid artery for a pulse. When we do blood pressure, we're looking at putting the stethoscope here at the cubital fossa to listen to the brachial artery. Down on the radial side is the radial artery. In the inguinal area near the femur is the femoral artery. Behind the knee is the popliteal artery. Behind the tibia, posterior tibial. And right between the first and second toe on the top of the dorsal surface of the foot is the dorsal pedal artery. Now, if this is weak or this is weak, especially in men, we'll see that with erectile dysfunction, poor blood supply to the lower half of the body. Oftentimes you'll see no hair distribution on the lower leg. Some people think it's from, guys wearing socks up here. But if you see people that have very little hair here, and then the hair continues nicely up here, it's poor blood supply down to this area. Oftentimes they'll get cold feet, and in men usually associated with erectile dysfunction.